in Iowa, there are multiple ACOs developing, and several of them are working together to collaborate to share expenses, shared services, and shared knowledge and learning. So we formed the University of Iowa Health Alliance, and it includes Genesis Health System in the Quad Cities, the University of Iowa in Iowa City, Mercy Cedar Rapids, and Mercy Health Network, which is Mercy in Des Moines, Mercy Sioux City, Mercy Mason City, Mercy Dubuque, and Mercy Clinton. And all these organizations are trying to work together to figure out how we do accountable care together, and whether we take risk or at least share services together. We all have ownership in the alliance, and one of the goals of the alliance is at some point to start doing joint contracting across the alliance. But we either have to clinically integrate or financially integrate before we can do that. And the first step for us in doing any of this is to integrate our data. And so that's what we're working hardest on right now, is integrating the data. We've been using disease registries for well over a decade now, and registries will tell you about a population of patients, say, with diabetes or coronary artery disease, and you can track them and know their clinical outcomes. Like, do they have their blood pressure controlled? Do they have their blood sugar controlled? Are they overdue for a visit? But you don't know anything about the overall health of that patient. You don't know whether they're utilizing the hospital more, whether you're not tracking whether they died or what kind of complications they might have had. We think if you do the right thing as far as blood pressure control, you will have less heart attacks, you'll have less deaths, but we don't really have that data to prove that in our own population. So we're looking at getting more sophisticated data systems that bring in the billing data now, and that billing data will tell us about the cost of care across the continuum of care, not just what we're delivering in our physician offices. So we're hoping that we'll be able to show that this cohort of patients that we manage blood pressure in better actually have lower costs because of less hospitalizations, less complications down the road. In the past, we've done all of our registry work has been manual data entry, and we had systems in all of our clinics where we would, after every visit for certain types of patients, enter data into our registries. Now we are linking to our electronic medical record, which we have up for about a year on all of our sites. So that feeds directly into our registries. We also have the billing data feeding directly into our registries. We have data from SureScripts with the pharmacy data feeding in. We have lab feeds coming into our registries. So we have this rich data that we match the patient across all these different sources, and it gives us a much broader view of what's going on. I think we can learn a lot more by taking this approach. We've been working on this for a long time, looking at, so you have the data, what do you do with it? And very early on, in the early 2000s, we were thinking, you worked with doctors on this, and we quickly learned that that didn't really work. Doctors are already have no extra time in the day, and people will go to doctors frequently and said, it'll only take you 15 seconds a patient. Doctors don't have an extra 15 seconds per patient. What we had to do is put systems in place that took 15 seconds less for the doctor and still utilize the data. So what we did was we hired nurses. We placed them in physician offices, and those nurses helped unload the work of the doctors. They did some pre-work for the doctors, they did some post-work for the doctors, making the doctor's life easier, but they also made sure that patients got all the needed lab interventions, cancer screening, immunizations. It turns out there's a lot of revenue that's generated from doing that. That easily paid for the program. The nurses also made sure that the doctors got their pay-per-performance money. So we had a private insurer for pay-per-performance program. The doctors who embraced these coaches really got the full payments from these insurance companies. So we integrated them into our clinics in a way that they actually generated considerably more revenue than the cost of their salary, and we were able to utilize them to improve the health of the population at the same time. That we're embracing this, we're all in. And so we want to get to risk-based contracting as quickly as we can. We want to get closer to that premium dollar. We see the fee-for-service payment systems is only going one way, less fee for each service, and we have to find another approach. So in Iowa, we are aggressively seeking out ACOs. We have 5 ACOs in Iowa, so it's not a very big state to have that many Medicare ACOs already. And we're working on trying to link them. We're working on bringing in more hospitals, trying to get them to grow. we're working aggressively for the health insurance exchanges to have a product there that's risk-based, and looking for our other partners to help us along that line.